Assalamu alaikum everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student. Inshallah, today I'll be going over the second part of the HNS crash course, and this one will be on ophthalmology. This crash course will cover all the eye, inshallah. I'll be covering concepts of anatomy. I covered a lot of the concepts of anatomy this time compared to yesterday. All of the clinical. Okay, every single disorder in clinical will be discussed today, and the micro and pharma as well associated with the eye. Now, before I begin, if you want to know details of the anatomy and physiology, you can watch Dr. Tala's PAL session on the eye and the vision and optics. Okay, that will go into more detail on that. Without further ado, and just like my PAL sessions, this will be a very interactive session. So I will ask questions and you guys answer me in the chat. So first of all is the bony orbit. What's very important about the bony orbit is you need to understand firstly the borders. Okay, and this is just straight anatomy in terms of where the borders are. The second thing is you need to know the boundaries that's surrounding the eye. Tamam? Why is this important? Is because you need to understand that certain pathologies can spread to the eye because of their close relationships with those areas. So مثلا, in the floor of the orbit, we have the maxillary bone. What's beneath the maxillary bone? Maxillary sinus. Why is this important? Is simply is that if you have, for example, if, for example, someone was in a fist fight and they got punched right over here, okay? So what will happen is you will have something called a blowout fracture, okay? So parts of the orbit, the contents, which is the muscles and so on, can herniate excellent into the maxillary sinus. And this will cause different manifestations, and we'll get to it. Then over here is that you have part of the medial wall is the ethmoid bone. What's or more medial to the ethmoid bone? Simple from the name. Ethmoid, what? Sinus. Good. Again, why is this very important? Is if you have ethmoid sinusitis or ethmoiditis, you will have direct spread from the ethmoid sinus to the eye. Okay? Exactly. So this could be a risk factor or the main risk factor for orbital cellulitis or preseptal cellulitis, and we'll get to what those are. This is why it's important for you guys to remember the boundaries and the bones in the orbit. But you need to know the boundaries well, and which bones make up the medial wall, lateral, the apex, which is the optic canal, the base, which is the external part of the orbit, the superior wall, and so on. Now, what's very important is the extraocular muscles. Okay, so in the orbit, we have 6 extraocular muscles that move the eye. Okay, so what do you need to know is what are these muscles, the innervation of the muscle, and the movement, and how you can test for these muscles. Okay? So simply, as if you look at this diagram, you will have 4 muscles, which is 1, 2, 3, 4. Okay, that is around each border of the eye, if you want to call it that. So let's just say the eye is a square, and each border you will have a muscle. And simply is that this muscle over here is in the superior part. When it contracts, it pulls the eye upwards. Tamam? So this muscle is a superior rectus. Its main function is elevation of the eyeball. Simple. Then we have lateral rectus, which is holding it in the lateral part of the eye. If it contracts, you have abduction of the eye. Tamam? Then we have the medial rectus, which is medial. So if it contracts, you will have adduction. So it brings the eye inwards. Then we'll have the inferior rectus, which will bring the eye down. So this is depression of the eyeball. Tamam? Then we'll have 2 important muscles, the superior oblique and the inferior oblique. Tamam? These muscles, when they contract, they act in a certain way, which is the superior oblique, when it contracts, it will cause encyclotorsion, which means that it will bring the eye inwards like this. It will contract like this way. So the eye will turn this way. So it will let the eye look down and out. Tamam? Opposite is inferior oblique. When it contracts, the eye will look this way. تمام. Why is this important for you? Is when you do physical exam and when you have certain pathologies that will affect the eyeball or the extraocular muscles, the eye will look in a certain direction. تمام. Now, what are the three nerves supplying these muscles? Tell me all three.
oculomotor, abducens, trochlear.
ممتاز. Good. So, let's start with the easy one. Abducens nerve supplies which muscle?
Lateral rectus.
ممتاز. Lateral rectus. Excellent. Then we'll have the trochlear nerve, which innervates which muscle?
Superior oblique.
Superior oblique. Very good. So, why do I isolate these two? Lateral rectus by the abducens, cranial nerve 6, superior oblique by 4, because the rest is all oculomotor. Tamam? So now, if you think of the function again, is that the lateral rectus will cause a abduction of the eye. So in this case, in an abducens nerve palsy, you will have lateral gaze palsy. Tamam? The eyeball that's affected will not look laterally. So in a term that we want to describe it, it's called esotropia. Tamam? The eyeball is internally rotated. Okay? And I'll describe these terms in a bit. Then we'll have superior oblique. Tamam? Its main function is in cyclotorsion. When it contracts, it will bring the eye to look down. Tamam? Down and a bit out. So in this case, if you lose this function, tamam, what will be affected? Looking down. Okay? So typically in a trochlear nerve palsy disease, it's described to you as they have difficulty going downstairs. They have difficulty reading a book like this. They can't read a book because you can't look down properly anymore. Tamam. And one other thing is if it happens in baby, okay, how they'll manage is basically if this is the affected eye, they can't look down. This is a good eye. So to compensate for this eye, they bend their neck downwards to look more with this eye, the good eye. Tamam. So these patients typically have neck pain. Okay. So this is basically the extraocular muscles in a nutshell. Tamam. Now we'll apply it by looking at the clinical exam. Okay. There are 9 directions that we look at, but to make it simple, this is medial, this is lateral, or this is an adduction movement, this is an abduction movement, elevation, depression. Tamam. So as I said, let's start with superior rectus. Superior rectus, elevation. Inferior rectus, depression. Lateral rectus, abduction, so abduction. Medial rectus, adduction. Then we'll have the inferior and superior oblique. Tamam. The superior oblique will bring the eye down. Just remember down or in cyclotorsion. The inferior oblique will bring it a bit up. Okay. Or in other words, another name for it is excyclotorsion. Tamam. Now, why do you need to remember these functions? Is because when we describe certain diseases, okay? The first classes of diseases that we'll look into is something called strabismus, okay? This is basically where you have a certain defect in the ocular muscles, okay? That will cause ocular misalignment, okay? Strabismus can be acquired, can be congenital strabismus, depending on what the cause is. Okay, depending on what the strabismus is. So it's basically due to a defect in the extraocular muscles. Tamam. So what are the types of strabismus that we have? We have 4, okay? And it's depending on where the defected eye is looking. So we'll have esotropia, exotropia, hypertropia, hypotropia. Let's go over it one by one. Eso is inside, okay? Inside. Exo is outside. So esotropia, if you look at it, the eye is looking inside. So what muscle is defected in this case? Take a guess.
Abducens.
This is the nerve. صح, good, correct. The muscle is lateral rectus. Okay. The lateral rectus is defected in this case. It can't contract to abduct the eye anymore. Okay. In this case, this one, exotropia. exotropia, the eye is looking outwards. Okay, so in this case, the lateral rectus is working because it's abducting the eye. What's malfunctioned is the adductor of the eye, adduction, okay, which is supplied by the medial rectus muscle. Tamam, this is exotropia. Hypertropia is if the eye is looking up. Tamam. Now there are certain causes of this, simply as if you remember trochlear nerve. Okay, that's one cause. Another cause is if you have, again, an orbital blowout fracture, or you have a fracture of the maxillary bone, the eye muscles, certain muscles, will get entrapped inside inside the maxillary sinus. In this case, because of the inferior rectus that gets trapped inside the maxillary sinus, because inferior rectus right here, the eye is going to look upwards. Tamam? This is hypertropia, eye looking upwards. Hypotropia is the opposite. The eye is looking downwards. Tamam? Now I'll go over the causes, but I'll answer the question chat. The lateral rectus is over here, so it moves the eye laterally. Okay? Medial rectus is medial, so it moves the eye medially. Does that make sense?
Also, the problem is in the lateral rectus, so the eye compensates by moving medial.
Exactly.
Alright.
Okay. So now we'll go over causes of each of these. There's some that I really want you to remember, and there's some that, don't worry about it. But مثلا, esotropia, I want you to remember is if the patient has certain refractive diseases, such as hyperopia or hyperopia, okay, which is near sinus. In this case, or these patients, they usually compensate by doing esotropia. Okay, so esotropic patients with this malfunction have hyperopia. I want you to remember this by heart. Esotropia and hyperopia. Okay, that's one. Then we go into hypertropia. Hypertropia is by, as I said, the trochlear nerve palsy. It's because you cannot look down. Tamam? Now, how do we evaluate these patients? Okay. So first of all is you look at over here. We shine a light in the patient's eye, and we see where the light is pointing at the eye. Usually, if we do it to anyone, me, you, everyone, is that the light will shine at the middle of the eye, right in the middle of the pupil. Tamam? In patients with strabismus, the light will be deviated. Okay, it won't be at the central of the pupil anymore. This is a true strabismus. This is important, very important for you to remember. So here in this case, this is a normal eye. The light is shined at the middle of the pupil. In this case, in a strabismic patient, it will not be in the midline. It will not be in the center. It will be deviated. Is this concept clear?
Yes.
So now, in this case over here, I'll get to your question. In this case over here, we do something called masking. And I want you just to remember it is if we try to diagnose patients with strabismus, sometimes we mask the good eye, not the affected eye, to see if the eye will compensate or not. If this bad eye will try to adjust itself or not. This will mask the good eye. Okay, we cover the good eye and we see the bad eye, and then we shine the eye, light in there, in this eye, and this will tell us whether or not they have true strabismus or not. This is a bit more advanced, but this is just for you to know. How esotropic patients have hypertropia? So hyperopia, okay? Hyperopia is when we get to lens diseases, and I'll explain what hyperopia is. But basically, hyperopia is near sinus, okay? So in these patients, how they will compensate somehow in children is by undergoing or going through esotropia. I'm sorry, by the way, if there's background noise, but esotropia. Okay, so hyperopic patients who have nearsightedness will compensate with esotropia. I want you to remember this association because In MCQs, it will come as esotropic patients typically have, or what association? Hyperopia, something like that. تمام. Cool. And just a fun fact is strabismus demographically is 2% of children are below the 3 years, and it does not have a female-male any predilection, but you need to remember the statistic. Now, why did I teach you guys the light reflex test? Is for you to look at this. What's this diagnosis? Do they have strabismus? Yes or no? I want you just to tell me that.
No.
Exactly. They do not have strabismus. They have something that we call pseudo-strabismus. Why? Is the light shining at the middle of the pupil? Yes.
Yes.
So in this case, it's normal. Now, what's high yield for you to remember is there are 3 important causes of pseudostrabismus. Number 1 is this thing over here. What do we call this?
Monolid.
No. Epicanthal folds. Excellent. Good. Epicanthal folds. I want you to remember this is a normal finding. However, patients مثلا with this finding plus this finding, which is a flat nasal bridge, could be signs of Down syndrome, just for you to remember. But epicanthal folds, flat nose, and then the eye distance, if it's very far or very near to each other. This is a bit far still, but if it's very far or very near to each other. 3 things that will cause pseudostrabismus. Epicanthal folds. Number 2 is flat nasal bridge. Number 3 is unnatural close or far eyes, distance from each other. High yield, okay, in clinical. Now we'll go to each eye extraocular muscle defect. Tamam. So this is the patient when you're telling them to look at you straight. Tamam, straight. In this case, you can see this eye. What finding do we see on this right eye? Look at the eyelid.
Ptosis.
Excellent. Ptosis. Okay. This is what we call ptosis. That's clue number 1. Number 2 is if you tell the patient to look up. This eye will look down and out. They cannot look anywhere else. So what's this disease? What cranial nerve is affected? Down and out, pupil or eye, plus ptosis. Ocular motor nerve palsy. Good. Why is this eye looking down and out? Is because the superior oblique is normal. The lateral rectus is normal. So it will pull this eye this way. Okay? Because superior oblique is by the trochlear. The abducens supply lateral rectus. So the eye can only move down and out. It cannot move anywhere else. So this is cranial nerve 3 palsy, ocular motor nerve palsy. It carries parasympathetic to the levator palpebra. So in this case, they will have ptosis. Okay?
I do have a question.
Yes.
So, if this is oculomotor palsy, what about the trochlear? Isn't the trochlear supposed to elevate the eye?
Yes. The trochlear is supposed to, it's for the superior oblique that will bring the eye downwards.
Okay.
Okay. We'll get to the trochlear, which is hint, this one. Okay. In this patient, they have trochlear nerve palsy. How do they present? As I said, is the trochlear nerve, its main function is a superior oblique, which is one of the main functions is to depress the eyeball. So in this case, this movement over here to look down and read the book, they cannot do. They cannot bring the eye downwards. So they'll be stuck at looking up. This is the function of the trochlear nerve, is to bring the eye. Its main function is the encyclotorsion plus the depression. And there's one tertiary function, but it's to look down. So these patients, when you ask them to look straight, you can see, or even try to look down, you can see that this eye is looking out, up. They cannot look down. So in this case, you can see that this is a cranial nerve 4 palsy or hypertropia. Okay, eye is looking up. These patients typically will deviate their neck towards the good side. Okay. Is this clear now? The difference between trochlear and oculomotor?
Yes, thank you.
Okay. Another thing is oculomotor has parasympathetic. This doesn't. Okay. This will be affecting also the constriction of the pupils. Okay. In oculomotor nerve palsy, if it's a central cause, usually will cause mydriasis. Okay. Dilated pupils. That's another hint for you. Now over here. Okay. In this case, this patient was asked to adduct both eyes, normal. Then they asked to go back to the midline and then try to abduct the eye. What cranial nerve and which muscles involved? Excellent, good. This is the involvement of the cranial nerve 6, which is going to be the lateral rectus. Good. So this is what we call esotropia. What refractive error is associated with esotropia? Hyperopia. Excellent. Good. Remember this association. In this case over here, can you tell that this patient has, let's just say, this patient over here is a pseudo, we'll get to what types of lens we use, inshallah. But in this case, is a pseudo strabismus or real strabismus? Look at this one. Real. Good. So, good. That's important. Okay, I want you guys to know how to tell the difference between pseudo and real strabismus, and then the types of strabismus that we have in terms of the extraocular muscles. Another thing is with newborns when they're born, what we do in newborn screening is we shine light in their eye, okay? And we look at the corneal light reflex. What's the normal color that we'll see from a corneal light reflex? Red. Good. What's an abnormal color? White. Mumtaz. Good. So in this case, it's red, both sides. So this is normal. Now, how about over here? We shine light on the right eye for these babies. This one is very white. This is black, but don't worry. Imagine it's white. What do we call this? Leukocoria. Okay? Leukocoria, or I wrote cornea, but chorea. Leukocoria, which is a white light reflex. Okay? Now, for you guys, I want you to remember two important differentials. What's number one? The most important, dangerous condition that can cause leukocoria.
Retinoblastoma.
Excellent. Retinoblastoma. I want you to remember retinoblastoma. Okay? This is super high yield and super important. We'll come. The other differential is cataract. These two are high yield for you to remember. Retinoblastoma number one, number two is cataract. Tamam. Why is this important? A, if it's retinoblastoma, you need to investigate it further and need to treat the disease, which is it's a tumor, it's a cancer. Number two is if it's cataract, you easily fix it. Okay. Now, what does this baby have? Retinoblastoma. What do you see on the CT?
Calcifications.
Calcification. Good. This is retinoblastoma. Okay. It's most likely going to be a genetic inherited tumor. Okay. From the retinoblastoma gene, مثلا. And a key thing that I want you to remember is it causes leukocoria. And number two is on CT, it causes calcification of the eye. Once you see these, you need to investigate it further and you need to treat these patients accordingly. You do not need to worry about what the treatment is. Now, for these patients, regardless of what the cause is for any strabismus, what's important is you treat this earlier. Why? Is when you have deviation of the eye or ocular misalignment or leukocoria, whether it's blocking the vision is supposed to go to the retina. And from the retina, it goes all the way to the brain. So the brain will perceive what you see. Okay. So in this case, if you have visual malrepresentation, or the vision, what you see is not being learned or presented to the brain, you're not going to need the eye anymore. So the brain is like, all right, I'm going to give up on the eye. So we develop a condition known as amblyopia, lazy eye, okay, which is visual decrease in one or both eye. The reason of it is if you have deprivation amblyopia, such as if the patient has congenital ptosis, cataract, occlusion, retinoblastoma, whatever, refractive amblyopia, such as hyperopia, okay, strabismic amblyopia, such as all the ones that we just described. In this case, you need to treat them very early on, okay? I don't want you guys to go into the management in detail, but just remember is firstly, if there's an identifiable cause, you treat the cause. Then number two is if it's refractive amblyopia, what do you suggest to give to the patient? Simple. They have a refractive disease. Glasses, good. Fix the refraction disease. Easy. Biconvex or biconcave lenses will describe what they are in terms of which one we use to treat which refractive disease later on. Thus, you give glasses. Easy. You fix the issue. The other thing is strabismic. This I want you guys to know a bit. So as I said, you correct the refractive error, ignore this. This occlusion treatment. So in strabismic errors, what you want to do is you actually want to isolate the bad eye. You want to have the bad eye that has strabismus to function alone, to try to work on its own. Why? Is if you have one good eye, one bad eye, your brain is going to automatically ignore the bad eye and just take whatever the good eye has. So what you do is you mask or cover the good eye. So this way, the bad eye will have to function and kind of carry you in terms of the vision. Okay, and this usually will fix. Okay, that's all I want you to remember for in terms of treatment of strabismus. Usually, again, it's due to some disorder of the extraocular muscles itself. So what we can do is we treat it with either botulism toxin to basically stop the, if for example, if the medial rectus muscle was if it was paralyzed, مثلا, the lateral rectus is going to pull the eye outwards, causing exotropia. So what you do is you put botulism toxin at the lateral rectus to put it back in the middle. And you're straightforward. Strabismic surgery is we cut the muscle. Strabismus and amblyopia, all good?
Yes.
So now we go to this. This patient was at a motor vehicle accident, a fight, something happened, yani, and then developed this. On this CT, you can see a lot of stuff in the maxillary sinus. And when you look at the examination, the eye is pulled backwards and inside, downwards. So the eye is looking up. What's the diagnosis?
Blowout fracture.
Excellent. Orbital blowout fracture. Easy. Okay. What muscles entrapped?
Inferior oblique.
Usually, the most common muscle to be entrapped is inferior rectus. I know it's right there. Inferior oblique jay, a bit like this. Okay. This inferior rectus is right on top of the maxilla. So it's going to easily entrap and cause the eye to look out upwards. Tamam. This is orbital blowout fracture. Okay. Now we have this patient over here. Tell me the diagnosis based on these findings. Excellent. What type of thyroid disease? Usually. Thyroid eye disease, more specific, is Graves' disease. Okay. Graves' thyroiditis. Tamam. Now, Graves' disease is a condition that you'll learn, inshallah, in more detail in third year in Repro. But it's basically a condition causing hyperthyroidism due to an autoimmune condition. Okay. Now these autoimmune condition means there's antibodies. These antibodies go to the extraocular muscles and cause edema because of, for example, glycosaminoglycans deposition and whatnot of the muscle. And this will cause edema of the extraocular muscles. In this case, when you have edema of the extraocular muscles, the pressure in this space will increase. So it will push the eye outwards. What do we call this sign? Exothalamus, good. Or ptosis. In this case, it's not ptosis, sorry, proptosis, which is eye going outwards or bulging outwards. If you look at it from the side method, it's very outwards. This is exothalamus, good. This is lid lag, okay? And this image in CT is very important, all three of these. Tamam? This is thyroid eye disease, and more important or more commonly, it's Graves' disease. Okay, this is muscle engorgement, and if they ask you which muscle, it's a medial rectus in this case. Tamam? Now, everything in terms of the orbit, the extraocular muscles, all of these, good. So now we'll go into the external eye anatomy. Now the eye in itself is very straightforward in terms of the external anatomy, يعني ما في أشياء كثير. In the middle over here, you have the pupil. Surrounding the pupil is you have the iris, which is the pigmented layer. Then we have surrounding, or just like a small little capsule above the iris and above the pupil is the cornea. Okay. Now, if you take a cross section like of the cornea and you look above of the iris, this is the anterior chamber. Okay. Or the anterior segment, sorry. Okay. And I'll get to it when I actually explain a cross section. Then this white part over here is called the sclera. Now, what's covering the sclera? The conjunctiva, the clear bit, okay, which is vascular. Tamam. Then we have the medial canthus over here, which will have the lacrimal papilla, which will drain into the lacrimal sac into the nasolacrimal duct, and we'll get to it in detail. And this is the normal palpebral fissure, the palpebra, which is the eyelids, which will have the normal hair follicles. Now, the important thing about the palpebra or the eye lids is that it will have specific glands, such as the meibomian gland, which secretes oil, which is full of lipids, and the other one is sebaceous glands. Okay, these are important. Then we have one thing over here, microscope, and you can't see it here, but there's something huge over here, which is the lacrimal gland, which will secrete tears. So that's basically what you need to know in terms of the external eye anatomy. Okay, then we go into the lid specifically. Now in the lid, as I said, this is the palpebra. Okay, now we have one gland over here that secretes this oily fluid. Okay, oil. This is the meibomian gland. Why is this important? Is if you have an obstruction of the meibomian gland, this will cause a certain pathology. Okay, if you have obstruction of the the sebaceous glands, the normal glands in the eyebrows, the eyelids, sorry, this will cause a certain other pathology. Okay, this is all you need to know. Next thing is the lacrimal system. In the lacrimal system, as I said, laterally and superiorly, okay, you will have the lacrimal gland. The supply parasympathetic is from the facial nerve. We know this. Then the drainage of the lacrimal gland is through for example, we look at the medial canthus, which is this part over here of the eye. We'll have the upper punctum and lower. It drains into the upper canaliculus and then the lower canaliculus. And this drains into the lacrimal sac, into the nasolacrimal duct, and it will drain into the inferior meatus of the nasal cavity. This whole thing needs to be patent. Patent means open. Because if you have obstruction of any of this or stenosis, this will cause certain pathologies. Now, what do we call the lacrimal system when we describe it in terms of pathology is dacryo. Okay, so either we have dacryocystitis, which is affecting the lacrimal sac, or dacryoadenitis affecting the gland. And we'll go to each of these pathologies as we go. So now over here, This patient over here complains to you with مثلا crusting, itchy eyes, an adult patient with scaling, they wake up with this. What is this on the, and you look at this crusting that's located on the eyelids. What is this pathology? So this is what we call blepharitis. This is usually due to meibomian gland dysfunction. Okay. Now, simply what I want you to remember is blepharitis presents in an adult, usually presents as crusting or scaling that's located on the hair follicles at the eyelids. تمام. And it usually causes itching. تمام. Now, what do you want to do in this case for these patients is lid hygiene. Okay, just lid hygiene, and you can give warm compresses as well. Okay, which is just, you know, the bag that you give when someone's sick has warm fluid, you put it. That's it. This is blepharitis. Okay, would you give antibiotics? We'll have to monitor the patient, but I want you to just remember for management of this is lid hygiene and what's it called? Warm compresses. Okay. Now, how about over here? Acute redness and swelling that develops on the eyelid. That's sty. What's another name for sty? Cordoleum. Okay. Now, what is this disease? Is if you have obstruction of the sebaceous cysts or sebaceous gland. Okay. An acute obstruction, which is usually due to bacteria, and it's usually due to staph. Okay. Just remember. Now, in this case over here, it's acute. So it will be red, swollen, and tender. These are key terms for sty, and you need to know this. Red, tender, and swollen. So what do you need to do is you need to treat them accordingly, which is usually with antibiotics. So this is a sty. If something's like this, which is chronic, usually asymptomatic, rubbery, and non-tender, what do we call this? Chalaison. Good. Now, what is it caused by? Meibomian gland obstruction, which is a meibomian cyst. Good. Okay. So that is a chalaison. The difference is this is obstruction of the meibomian gland. The other one was not of the meibomian gland. Chalaison is chronic. C for chronic. Sty is more acute. Sty is acute, so acute inflammation, so pain, tenderness, redness. In chalaison, it's rubbery. Okay. Non-tender. Usually these patients are asymptomatic. However, it just causes bothersome symptoms because it's a huge thing. And when they close their eyes or open their eyes, might just cause a bit of discomfort. Okay. This is chalaison. Tamam. Now we go to eyelid disorders. So in this case over here, the eyelid is moving in a certain direction. Which way is it moving? Inwards, like in itself, or outwards? Outwards. This is what we call ectropion. Okay. Think about it, is if they have outward eyelids, will the eyelids be able to contain the fluids of the eye, the secretions? Think about it. No. So what is their main symptom? Not the tearing, because excessive, that will cause dryness, because it's not going to be able to contain itself. So it's just going to go. It's not going to keep itself in the eye. The tears won't stay here. So it'll cause dryness. Excellent. So that is ectropion. The more dangerous one that we want to, and we treat this surgically. The more dangerous one is this. What is this? Entropion. So why is entropion more dangerous?
Infection.
Not only infection, but because it can cause blindness. Why? Is because you see these eyelids, it's going to irritate on the cornea. It's going to keep irritating cornea. And you can see that the cornea is starting to become more opaque. Now, if we are corneal abrasion, excellent, it causes corneal abrasion. I want you guys to remember this one thing is if we are suspecting corneal abrasion, what do we test? How do we test for corneal abrasion?
The yellow, green, something, the dye.
The dye, what's the dye called? Fluorescein dye. Good. Okay. Fluorescein dye. Excellent. So fluorescein dye is this blue dye. Okay. And you know, on your slides for Dr. Salwa, there's a picture of her looking at someone's eye from a distance, or like the slit lamp, that thing is in the slit lamp itself, which will look at the interior segment, which is all of this, is we put a dye. This blue dye will allow us to see any corneal abrasions or even corneal ulcer if it deepens. I'll explain what's the difference between them later on. I'll show you fluorescein dye. Yeah, that's what's dangerous about entropia. Now, how about this? Here, the eyelid is normal, but the eyelashes are internally. They're scraping on the cornea. What do we call this? Eyelids are normal. It's not inside. Good. Another trichiasis. Good. Which is usually caused by chlamydia, which is trachoma. Okay. One of the more common causes of blindness. This is trichiasis, which is the inward movement of the eyelids. Sorry, the eyelashes, not the lids. The lids is entropia. Eyelashes only is trichiasis. And this is important in high yield. So that is that. Now we go to this patient. This patient was immunocompromised or diabetic or whatnot, and later on presents with a rash, vesicular rash that's very painful and burning, only in one distribution of the trigeminal nerve, which is the ophthalmic distribution, and it's affecting the eye. And it's causing this appearance on the cornea when we do fluorescein dye. What is this?
Human simplex virus.
Not simplex, zoster. تمام. This is herpes zoster ophthalmicus. This is dendritic keratitis. I don't blame you for saying herpes simplex at all, actually. It's good that you mentioned this. But the difference between them is, number one, the case that I gave. The case indicates a patient who had, let's just, for example, chickenpox. Varicella zoster. That's what this virus is. Later on, it lays dormant. Tamam? When it lays dormant, it can be reactivated when a patient is immunocompromised, has diabetes. Okay, it can reactivate and cause herpes zoster ophthalmicus. Why is this dangerous for us? It could cause dendritic keratitis. Keratitis is an inflammation of the cornea. So over here, you can see during a fluorescein dye, you can see that fluorescein is blue. So it stains the cornea blue. So you can see here that there are corneal abrasions in a dendritic formation. This is herpes zoster ophthalmicus. This patient is a bit different, okay? This is herpes simplex. Now, HSV can affect, for example, the eye, and this is mostly in children. Okay, I'll tell you this. However, it can present in any age and does not have usually the risk factors of herpes zoster, which is reactivation. Zoster is reactivation. Simplex is not. تمام. Again, fluorescein dye will show you this dendritic appearance. تمام. In this case, come on over here, if you want to look at, it's not really respecting one distribution of the trigeminal. Okay,
Makes sense. Thank you.
no problem. Then we go to more eyelid diseases. This patient has hyperlipidemia, high lipid, and they have lipid deposition in the eyelid. What do we call this? Xanthelasma. ممتاز. Xanthelasma. Is high yield? I doubt it. I doubt it will come. This is something you learn a bit more in third year with certain hyperlipidemia syndromes or the familial hyperlipidemias. Okay. This is something you learn later. What is high yield kind of, actually not really. This one is a patient who went outside. It's very windy outside. It's spring and there's a lot of pollen in the air. Later on comes back inside and has a swollen eyelid. What is this? Allergy. So allergic eye swelling. Usually it's a patient with atopy, has other allergic symptoms. So for example, has rhinitis, eczema, asthma, and then due to the specific allergen, they have allergic eyelid swelling. تمام? That's pretty much straightforward. Now this is actually important. What is this? Think from MSI,
squamous cell carcinoma.
the counterpart. Remember pearly, telangiectasias,
So basal.
basal cell. Good. So this is basal cell carcinoma. The risk factor, it's the most common skin cancer. The risk factor is sunlight. تمام? Ophthalmology related is, you need to remember, is this the medial? This is the nose. Is this the medial canthus or lateral canthus? Medial. Is this the upper or lower eyelid? Lower. This is the usual location. Okay. And it's the most common. You need to remember this. Now, in terms of the histology, there's two forms, nodular, and you can see the basal cells, if you remember from MSI, the palisading appearance or the pseudo palisading appearance. And this is another type, which is the morphia form or whatever. Okay. So that's basically basal cell carcinoma. How about this patient? The counterpart to basal cell had actinic keratosis, remember from MSI, the risk factor, developed into this ulcerating, bleeding mass. Squamous cell carcinoma. Do we need to talk about it in detail? No, ignore this. Do know and remember basal cell carcinoma. This is also kind of new to you guys, but it's a very important differential when we look at, for example, someone who had multiple chalazones, STI, and so on. It's an important counterpart, which is again, this one is sebaceous adenocarcinoma. Good. So as I said, the sebaceous glands are located in the palpebra and the eyelids. So if you have adenocarcinoma of those glands, you will have sebaceous adenocarcinoma. Now, important thing about it, there's important terms about how this thing spreads. I forgot how the term was. Pagetoid. Yeah, good. So the pagetoid spread basically means it invades inside, inwards. Okay, so this is sebaceous adenocarcinoma. Sebaceous adenocarcinoma. So now how about this eyelid disease? Give me just one moment, guys. I'm gonna mute just a second. Okay, never mind. Okay, so now in this case over here, what do these patients have? Ptosis. Now I'll give you guys differentials for ptosis. Okay, I will give you symptoms and you tell me what type of ptosis, what differential for ptosis is it? Okay, now you have a patient with ptosis. Okay, constricted pupils and lack of sweating to the same side. What is the defect?
Horner.
Horner syndrome. Good. ممتاز. Okay. Ptosis, dilated pupils, and down and out eye. Oculomotor palsy. Excellent. تمام. Now, patient has ptosis that is variable and fluctuating throughout the day. Usually worse at the end of the day. Myasthenia gravis. Good. These three, memorize them by heart. Patient with ptosis, meiosis, constricted pupil, and anhidrosis, Horner syndrome. Anhidrosis, lack of sweat. Next thing, is ptosis, midriasis, down and out pupil, or down and out eye, it's gonna be oculomotor nerve pulsing. Next thing is ptosis plus proximal muscle weakness and so on. Female patient in her 30s to 50s, myasthenia. The key term about myasthenia is variability, fluctuating, key term. That is ptosis or blepharoptosis. How about this patient over here? Blepharospasm, usually due to contraction of the orbicularis oculi muscle. And in this case, there's many causes of it. You don't need to know. One thing is if we want to treat it, Botox. Okay. That's basically that. Here is something called hemifacial spasm. Don't need to know too much about it, but it's basically facial nerve spasm when you مثلا sleep or whatever. Okay. Again, don't worry too much. Now, how about this patient? This baby, the mother's complaining to you the fact that they cannot stop tearing up. The tears are not going away. What is this called? This is nasolacrimal duct obstruction. Perfect. What's another name for it? Do you know? Dacryostenosis. Perfect. Now, in these patients, how do you want to manage them? Tell me one thing you want to do.
Remove the blockage.
How would you want to start by removing it?
Press down, I think.
Massage it. Okay, massage it. You massage the area, and that usually will help you relieve this obstruction. Okay, massage it. If this didn't work, then we go to surgical methods, such as dacryocystorhinostomy. Okay, that's the name of the procedure. But basically, if you have in the medial canthus, is you have, for example, the puncta with the superior and inferior, and then you have the canaliculus, and then the nasolacrimal with the lacrimal sac, and then the nasolacrimal duct. Obstruction of any of these will cause this dacryocynosis. Okay. Now, in this case, you start first step in management is you massage. Then, if it didn't work, surgery. Remember massaging. Remember the presentation. Remember this cause. This is kind of important. Now, this one over here is you have a swelling at the medial canthus.
Infection of nasolacrimal duct.
Perfect. What do we call that? Dacryocystitis. Good. Dacryocystitis, inflammation of the nasolacrimal sac, the lacrimal sac, nasolacrimal duct, whatever. Okay, and it usually presents as a enlarging mass, red swollen mass at the medial canthus. Okay, that's crucial. Don't worry how to manage this patient, but it's very straightforward because it's a bacterial infection. Now, how about this patient? Again, what gland do we have over here? The lateral superior part of the eye. Lacrimal gland. So if we have inflammation of the lacrimal gland, we call it dacryoadenitis. Tamam? Straightforward. Again, you just need to identify these by the images. Okay. Now, here, I don't want to go too much into detail into you diagnosing this, but I want you to remember certain things. In this case, this is eyelid laceration. What do you want to do? Call ophthalmology. Okay, done. Call ophthalmology, surgery. This is eyelid trauma. One other thing about eye trauma in general, and this is something that we'll go into when we talk about corneal trauma, is you need to identify what type of trauma there is. If they have eyelid laceration, eyelid trauma, eyelid whatever, you look for different trauma. Okay, and I'll get to how later. Now, important things is preseptal and orbital cellulitis. Separating the palpebra from the rest of the orbit or the orbital fat is this, which is the orbital septum. If you have an infection that spreads from the ethmoid sinus, wherever is sinus, okay, usually ethmoid, to this area that is before the septum, this is what we call preseptal cellulitis. Yeah. If it invades and goes past the septum, this is what we call postseptal cellulitis or orbital cellulitis. Why is this important? Why is this important? Is if you have, for example, preseptal cellulitis, okay, will this affect the extraocular muscles and the vision and so on? No, it will not. What will it do? Just eyelid swelling and erythema and ocular pain. That's it. Fever as well, because whatever. Yes, it might come as a secure. If it involves the septum or it goes beyond the septum and involves the orbit, what do we have in the orbit? Muscles. This orbit is a closed space. So any infection that happens here, orbital cellulitis, the pressure here builds up. So you'll have any ophthalmoplegia. You'll have diplopia, proptosis, because there's pressure increase, so the eye will bulge outwards. Okay? And pain with eye movements. This is crucial and high yield for you to remember. If this patient comes to you with just, you answer me, what's the diagnosis? If just eyelid swelling, okay, some pain and fever, what's the diagnosis?
Preseptal.
Preseptal. If they present to you with diplopia, proptosis, eyelid swelling, visual defects, ophthalmoplegia, can't move their eye downwards, مثلا. This is orbital cellulitis. What's the risk factor? Usually is sinusitis. Tamam? This is high yield. Now we're going deeper into the eye, and inshallah even quicker, yani we'll get through this very fast. As now we go into the external eye. So this is when I said about the cross section. This over here is the cornea. Then we'll have the iris. This portion over here from the iris anteriorly is what we call the anterior segment. Below it, until the lens, is what we call the posterior segment. Tamam? Now, also another thing is, yeah, okay, that's basically that. Over here, from the lens upwards, what fluid is inside this cavity? Aqueous humor, good. Which is produced where? Where here? Ciliary body, good. Tamam. Now below the lens is going to be vitreous humor. Tamam. Now this is what we look at in terms of the eye itself. We pull the eyelid down and we can see the clear conjunctiva. There's multiple parts of the conjunctiva, such as the ocular part, the palpebral part, and then there's like the middle portion between them. Tamam. And we need to look at it to look for any pathologies that happen to the conjunctiva. Now, any conjunctival disease that will turn red will cause red eye, conjunctivitis, which could be viral, which could be bacterial, which could be allergic, which could be so many other things. Also in the sclera, if you have any defects of the sclera, it will start to have a specific color. Okay, we'll go through this one by one now. Another thing is over here, I don't think there's anything else I want to go over, but if we look at the layers of the eye from outside to inside, from the conjunctiva, you'll have the sclera, then the choroid, then the retina, and then over here is the vitreous. Now this over here is we'll have the vascular tunic, which is going to be the iris, then the ciliary body, then the choroid. Now over here is the retina. The retina, there's two layers. There's the pigmented layer and there's neuronal layer. Why is this important? It's for retinal detachment, and we'll get to it. I think that's it for here. Now we'll go into the pathologies one by one. Firstly, is if we want to look at the inside of the eye, okay, we do something called fundoscopy. Fundoscopy will allow us to look at the retina. What are some things that we want to look at in terms of the retina? Okay. Firstly is, what do we have over here?
The macula.
Macula, good. So the macula will have all the highest amount of concentration of the cones and the rods, the cells, the photoreceptors. تمام? Most of your vision will go, like the axis of your vision will go to the macula. Now, the macula has a spot over here called the fovea. Okay, what's important about this is one of these cells is absent in this part. Then we look at over here. What's over here?
The optic disc,
Optic disc. What's inside the optic disc?
the nerve, optic nerve.
Okay, this is all the optic nerve, but we call this optic disc. This is called the optic cup. Good. When we look at any diseases of the retina, we want to look at a couple of things. Firstly, let's start by the macula. The macula needs to be patent like this. You can clearly see it. If you have spots around the macula and this patient starts to complain to you of central vision loss, this is a disease. Okay, that's number one. Number two is if you have, for example, we look at the blood vessels. Okay, the blood vessels, we look at if there's any neovascularization, if there's, for example, any thinning that's happening in the blood vessels, indicates certain diseases. Is there any hemorrhages happening here? That's certain things we look at in a fundoscopy. Then we look at the optic disc. At the optic disc, we look at if it's clear. We can clearly tell the borders of the entire optic disc, which is normal. We want to look at that. If you have, for example, optic neuropathy, optic neuritis, where it's going to be edematous, this is going to cause a certain finding where it's not going to be clear. You can't tell the borders of this. I'll show you. Another thing that's important is the optic cup to disc ratio. The optic disc should be huge, like this. Optic cup is smaller. If the optic cup starts to become bigger, this is a certain diagnosis that you put in mind with other symptoms. This is just introduction. I will go over and explain all of the pathologies that you will see in fundoscopy. Okay, and make sure that you guys remember it. Let's start over here. You have this patient who, when you take history from them, is they tell you, oh, I have allergies. Yani I have eczema, I have rhinitis, I have whatever. And they complain to you that with these symptoms of rhinitis and whatnot is they have runny, they start to tear up a lot. What is this? And you look at their conjunctiva and it looks like this. What is this? Allergic conjunctivitis. Good. What can you note from this appearance of the conjunctiva? Papillary. Guys, please remember that, please. Okay. Papillary appearance and allergic conjunctivitis. They usually typically present with tearing eye, bilateral, okay, red eye, conjunctivitis, and they usually have a history of atopy, atopic diseases. Yesterday, we talked about rhinitis, we talked about those diseases, asthma, and so on. They'll have allergic conjunctivitis. Tamam? Easy? Inshallah.
Yes.
Now, how about here? This is a different pattern, not papillary appearance, but this is more follicular, I think. In this case, this is viral conjunctivitis. Now, if you have a viral conjunctivitis, this appearance, okay, red eye, plus pre-auricular lymph node involvement, what virus do you think of? Most common viral cause. Bilateral conjunctivitis virus. Most common virus.
Influenza,
No. Adenovirus. Adenovirus is the most common cause or viral cause of viral conjunctivitis. Now, here usually, in this patient, they will have discharge, which is very clear. If it starts to become purulent or mucopurulent, this is purulent. If it starts to look kind of liquidy, any more liquidy, but it's clear with white, this is what we call mucopurulent. This is what we call bacterial, okay, conjunctivitis. Tamam? In this case, we have multiple types of bacterial conjunctivitis. Can be caused by staph, strep, Haemophilus, Moraxella, and very importantly, is chlamydia and Neisseria. These are the ones that I want you to remember. Neisseria and chlamydia, especially chlamydia. We'll go into details. So these are important bacterial causes. Here are the viral and some of the bacterial causes of conjunctivitis. By far, viral cause, remember adenovirus, most common one. Now, if we look at acute hemorrhagic conjunctivitis, which we'll look into and I'll show you, it's associated with these viruses, enterovirus and Coxsackie virus. Okay, these are the two viruses associated with the acute hemorrhagic conjunctivitis. Then we look at chlamydia trachomatis. It has multiple serotypes. You have types A, B, BA, and then C, which will cause trachoma. D to K will usually cause the inclusion conjunctivitis that I'll show you, which is a congenital, not congenital, but it's a form of conjunctivitis that happens at birth. Okay, and I'll explain that. Neisseria gonorrhea is another one that happens in the newborn. Then these agents which cause a bunch of stuff. Okay, don't worry too much about this. These ones, these two, plus adenovirus is very important. Okay. And these two for hemorrhagic. Now for neonatal conjunctivitis, which happens in newborns, I want you to remember, ignore chemical, but I want you to remember Neisseria and chlamydia. Neisseria happens more acutely, 2 to 5 days, bilateral purulent. Okay. Chlamydia happens afterwards, so more than 5 days later, 2 weeks. Okay. Starts unilateral and then bilateral. Okay. And it's usually mucopurulent discharge. How do we treat this? This one we give, if we want to give prophylaxis, we give erythromycin topical. To treat it, we give ceftriaxone. Remember that. Okay. Chlamydia is erythromycin orally. Okay. This causes inclusion conjunctivitis if it's in newborns. I just want you to remember both of these. Okay. Ignore the rest. Especially when it comes to the timing. So what is this? Newborn, around 7 days, produce mucopurulent conjunctivitis.
Chlamydia.
Excellent. This is called inclusion conjunctivitis. What serotypes of chlamydia? We said, we have two diseases that chlamydia can cause. Trachoma and inclusion conjunctivitis. Trachoma has their own serotypes. Inclusion conjunctivitis has their own. I want you to remember for inclusion conjunctivitis is D to K. Okay. So this is inclusion conjunctivitis, chlamydia trachomatis, types D to K. Okay, high yield. Now, what is this disease? It says it's right here.
Trachoma.
Trachoma, good. So in this case, this is caused by chlamydia trachomatis. So the types A, B, BA, and then C. A to C, if you want to remember it. What's important about this is going to cause trichiasis, which will cause blindness. Okay, corneal ulcers and corneal abrasions and whatnot. Now, what do we see? What stain is this? This is what we call Giemsa stain. Okay. And what form of chlamydia do we see here? There's two forms of chlamydia. Elementary. Excellent. Good. Elementary is intracellular. And what's extracellular? Reticulate. Excellent. Reticulate is what will spread. Okay. Elementary is intracellular. And you can see it on Giemsa stain. Tamam. That's basically this in a nutshell. Then we have this one. Hemorrhagic conjunctivitis. Good. This hemorrhagic conjunctivitis caused by what? This is a bilateral sudden hemorrhage with discharge, itchiness, enterovirus, or you can just say picoRNA viruses, okay, such as enterovirus, and I mentioned the in the table. تمام. What's important is just don't itch because it can spread to the other eye. تمام. This is acute hemorrhagic conjunctivitis. Now over here, this patient, due to repetitive trauma, and by trauma I mean air hitting their eye or مثلا dust hitting their eye repetitively, UV light, wind, dry eyes, they develop this growth that happened on the conjunctiva. What do we call this?
Trigum? Trigum?
No, the other one. This one is pingecula. Okay. This one is pingecula. Pingecula is this non-cancerous growth that happens in reaction to some trauma, irritation. Okay. Will this come? Unlikely. Let's to remember. Now, how about this? This one is the one you mentioned earlier. This is the pterygium. Okay. So in this case, it's just this membrane that forms over the cornea, and then it goes and attaches over the cornea. Okay, this is pterygium. Now, what's happening over here?
Foreign body.
Foreign body. Now, any eye trauma, you need to investigate for these things because you never know what you can miss. What's the dangers of this thing is it can migrate and dislodge and cause orbital rupture. Okay, goes inside the eye. And what's dangerous about the eye is, if you remember, firstly, is your immune cells does not know eye antigens at all. It doesn't exist to them. Similar to testes. So once you have any opening that allows the immune system to go to the eye, it will cause blindness. Simple. Okay. So that's why you need to check for these things. Okay, foreign body. Here is you have corneal foreign body. And what's very important is you look for trauma, as I said. So this is ocular trauma, and this is a characteristic dislodged pupil. Okay. It's basically, we can have a name specifically for this. I think it's a teardrop pupil. You can look at this pupil over here and it looks like a teardrop. This indicates that there is ocular trauma. Now, one thing about ocular trauma that I want you to remember is chemical burns. Okay. Chemicals, we have two types, acidic, alkaline. Which one is more dangerous? Acidic or alkaline? Okay. We have 50-50 in the chat. Why is alkaline more dangerous? Alkaline, why?
Maybe
Think
more
about it.
erosive.
Very erosive. That's number one. Your body has no defense mechanism against alkaline. Acidic, yes, you can produce more bicarb at the area. Method. You can give bicarb at the area. Solve the issue if it's acidic. Alkaline, what can you do? Give acid, you damage more. Okay. So alkaline is worse. Alkaline is more erosive. So what do you want to do? Irrigate. Excellent. You wash the eye. Keep washing for a long time. That's it. So I think that's it for this one. Now we get to this. And I gave the answer. This is subconjunctival hemorrhage. It's normal, and this is can be seen in a lot of patients. Well, what's usually the risk factor here that can cause subconjunctival hemorrhage? What do the patients do that would lead to subconjunctival hemorrhage?
Rub the eye.
Rub the eye can, yes, but something very physiological. Valsalva maneuver. Good. So when they do any movement that is Valsalva related, تمام? So for example, lifting something heavy, sneezing, coughing, this can cause subconjunctival hemorrhage. Other than that, rubbing the eye is good, very excellent. Another thing is hypertension. Okay, that can cause subconjunctival hemorrhage. In this case, there's nothing to worry about. It will go away. Don't worry. Yeah. Now, how about over here? this patient is complaining to you of bilateral eye pain or itchiness, and you look into the amount of tears that developed, and it's low amount of tears. So what is this? Dry eyes or sicca? Good. We covered this in detail yesterday in terms of dry mouth and dry eye. But what do you want to give to this patient to relieve them of dry eye? Think
Eye
about it
drop.
there. Excellent. Artificial tears. Okay. And then you find out what's causing the dry eye or the sicca and you treat it. Now, now we go to the cornea. The cornea has 5 layers. Is everything clear before that?
Yes.
One thing I did not mention is in allergic conjunctivitis, we use cold compresses. Well, I want you guys to remember. And one last thing is in HSV in the cornea, it causes decreased corneal sensation. I want you guys to remember these 2 key terms. Best. Other than the stuff I've already mentioned and emphasized. Now the cornea. Okay. The cornea has 5 layers: epithelium, Bowman's layer, stroma, Descemet's membrane, and endothelium. تمام. Most important is endothelium, epithelium for you guys to remember, but I want you to remember one other thing, which is the stroma. Because if you have an damage to the epithelium, this will cause corneal abrasion. If you have epithelium, Bowman's straight into the stroma, this is ulcer. تمام. That's it. So how about here? Involving only the epithelium.
Abrasion.
Abrasion. Good. What dye did we use here?
Fluorescent.
Fluorescein dye. Excellent. This is the corneal abrasion. Yeah. Now, how about over here?
Ulcerative.
Corneal ulcer. Good. The cause of this could be infectious, could be traumatic, and basically involves the epithelium and into the stroma. تمام. Now, what is one risk factor that patients use that can cause corneal ulcers if it gets infected? There's people who wear glasses.
العدسات.
عدسات, excellent, good, which is the contact lens. Okay. Contact lens you need to remove. So contact lens you need to remove and clean properly. If you don't, this will cause corneal ulcer because you can get affected. Now, how about over here? This is
Worm.
worm. What do we call this worm? Micro. Onchocerca volvulus. Good, which is called river blindness. Tamam. This is called river blindness. How do you want to take a biopsy here? How do you want to get the sample of onchocerca? Skin snip. Perfect. Onchocerca volvulus causes the river blindness, which is, you can see the worm over here. You should go into a bit more detail of the life cycle and how it can cause infection, how it reaches your ulcer in the first place. But one thing is when you try to diagnose it, we take skin snip. Okay, these are just key terms. In this case over here, you have this cornea that is very edematous. This is one of the causes of leukocoria. Okay, and there's not much for you to remember here. Now, is if you start to involve the conjunctiva and the sclera, this is what we call episcleritis. Okay, or it's usually, yeah, the episcleritis. When would we see episcleritis and in another case scleritis? Okay, is in autoimmune rheumatologic diseases typically. Okay, autoimmune rheumatologic diseases. تمام. This is episcleritis. This is one thing I wanted to remember. 1 second, please. طيب. This over here is episcleritis. Now, episcleritis, I want you guys to know, is it is commonly seen in rheumatologic diseases. بس. Okay, you don't need to identify it. Now, in this case over here, this patient has scleritis. Why can I say this is scleritis and not episcleritis? What's below the sclera? Anatomically, what's below the sclera?
chamber itself.
لا يعني layers, we have 3: sclera, choroid, retina. So what's below the sclera? Choroid, which is colored purple/blue, which is this. That's why we can say this is scleritis. Again, what's important about this is its association with rheumatologic diseases. تمام? That's it. Now, what this one? Someone who had trauma presenting to you with this finding, which is blood accumulating in the anterior segment. What do we call this? High FEMA. Good. That's all I wanted to remember. Trauma-based. The trauma is the cause, and it's basically blood that's collected in the anterior segment. تمام? Now we go to the lens and the lens diseases. We're almost done here. So what's the main function of lens? Simple. Lens and the ciliary body and the suspensory ligament. What's the main function?
To focus the vision
Focus,
itself.
refraction, and accommodation. Thus, I want you to guys remember these key terms in terms of your clinical. The details of how it works, the ciliary muscle, what happens when it contracts and relaxes, the suspensory ligament, this is purely physiology. تمام? Now, what's important to you about lens is how do you detect refractive errors is through prism test. That's all I want you to remember. How do we test it? How do we test for refractive errors is through the prism test. Now, what are the refractive errors? This will come in multiple forms. Physiology will love to ask about this. تمام? So how will they ask you this? Is you have someone, for example, who has a clear near vision, but when you ask them to look far, it's blurry. What disease is this, or what condition is this? What refractive error is this? They can see
Myopia.
clearly near. Excellent. Myopia. So in this case, if they are looking normal, like near, for example, if I have this book, okay, and I'm looking at it and it's near, okay, and I can see it clearly. In this case, the lens, do I want to make it more converge or more diverge? So if looking closely is normal, I want to look far. Okay, so my issue is looking far. Okay, basically what's happening is that the refraction is too short. Okay, so I want to put it a bit further. How do I do that? By concave, diverging it. Okay, making it a bit going a bit further. Does that make sense? Near is good. I can see near, but I want to see far. My issue is looking far. So what do I want to do? Is I want to make my glasses more divergent, meaning is that the light, when it comes to my eye, it will diverge away. Then with the lens, it will converge into the macula. Does that make sense? Because near is normal, okay? Myopia, we treat it with concave lenses. Done, okay? That's it. Hyperopia, relax, the opposite. Far vision, very good. Near vision, bad. So what do I want? I want glasses that will help me bring the light closer, converge the light very fast. So we have convex lenses. Okay. This is hyperopia. Now, what's the key thing about hyperopia is we said which strabismus is seen in hyperopia?
ESO.
Esotropia, good. Then we have presbyopia. Presbyopia is similar to hyperopia, but it's age-related, and it's basically due to what's it called? Age-related decreased power of the lens itself. تمام? Decreased accommodation. This is happening in elderly. Astigmatism is blurred vision at all stages or all distances, and it's basically because of the cornea. Okay, the cornea has an abnormal curvature. So in this case, no matter where the light is coming into your eye, it's going to be blurred. Okay, whether it's far or near. Here in this case, we treat it usually with cylindrical lenses. That's something for you to remember. Physiology, how will they test you? Usually is this. They will tell you, myopic patient, they can see good near vision, far vision is bad. How do you want to treat it? Concave diverging lenses. Okay. Hyperopia, the opposite. Presbyopia is age-related and it's very similar to hyperopia in how we treat it. So that's why if you look at it as in elderly, they wear reading glasses. Okay, because they have very blurred near vision. Astigmatism is a complete other pathology. It's because of abnormal curvature of the cornea. In this case, we treat it with cylindrical lenses. These are the refractive errors, and I want you to remember each one and how we treat it. Okay, this is in physiology and somewhat in clinical. Tamam. Now, the lens itself should be clear. If it starts to become like this, what's this disease?
Cataract.
Cataract, good. So cataract happens in elderly more. Okay, so one of the most important risk factors is age. Then you have other diseases that can cause it. If someone, give me a medication that can cause cataract. Medication. This one I kind of want you to remember. One of the most commonly used medication to treat inflammatory diseases. Steroid. Yes, steroids. That's number one. Diabetes, number two. Okay. Then we have other disorders such as genetic diseases. Okay. We have congenital diseases, inherited diseases, such as, for example, galactose metabolism disorders. Okay. We have infectious causes. We have so many causes. What I wanted to remember is how do these patients typically present is they have decreased vision at night and they see halos and they have decreased vision, but more at night. Okay, this is how cataract presents. How do we treat this? Surgically. We remove it surgically. Okay, that's it. Now, how about this lens dislocation patient? Marfan syndrome. Which direction is the lens dislocating? Superior laterally. Good. Or out and up. Okay, good. Marfan syndrome. You guys have studied it multiple times with mole, MSI, and so on. Okay, Marfan syndrome. Just remember the lens dislocation. I doubt you guys would ask this in detail. Now we go into the aqueous humor. As you guys answered me in the beginning, is where is it produced? In the ciliary body. Tamam? In the non-pigmented epithelium. This aqueous humor will go from the posterior chamber and go into the anterior chamber. Tamam? In the anterior chamber, you'll have two ways that it can get absorbed. We have the trabecular meshwork and then the trabecular outflow through the canal of Schlemm, which is 90% of the cases or 90% of the time is how we get it drained. And then we'll have the 10% through the uveoscleral outflow. Now, if you have a disease that will close this angle over here acutely, what pathology will develop? Glaucoma. Tamam? Glaucoma. Closed angle. Is it worse or open angle is worse? Which one's more acute, more severe? Okay, more acute, more severe is close angle. I'll explain why. What happens in open angle? This angle is open. ما فيها شيء. Okay, what's happening is you have decreased absorption. So this, in these patients, it's more chronic. It's more long-term because they just have decreased absorption. Okay, they can find it incidentally or they'll have decreased vision over time. Okay, that's how you could tell the difference between them. If you have acute angle closure glaucoma, so closed angle glaucoma, they'll present you with a very swollen eye, a hard eye, dilated eye, decreased vision, and it's usually in response to something. Okay, so مثلا, if you get a mydriatic agent, let's just say if someone's about to do an eye exam, we usually give a mydriatic agent, which is dilating agent. In this case, if it dilates, it can close this angle. تمام? In this case, if it closes angle, acute closure angle glaucoma. Another method is someone at the cinema. Okay. At the cinema, what happens is you have, because of the method, it's a very dark environment, صح? So in the dark, do you dilate or constrict?
Dilate.
Dilate, same thing. Okay. So it's usually explained as an elderly woman, مثلا, or male, that presents you with sudden onset, severe eye pain, decreased vision, dilated pupil. تمام? These are important findings for acute closure angle glaucoma. Open angle is chronic. تمام? These are important differences. Now, how do you want to treat glaucoma? Simple. Is you treat it by either increasing the outflow or decreasing the synthesis of aqueous humor. Done. How do you want to diagnose it? What is the diagnostic modality to check for pressure inside the anterior and posterior chamber? How do we check the pressure?
It's a device.
It is a device. Good. It's something called a tonometry. Okay. This tonometry will check for the intraocular pressure. What is the normal range of the intraocular pressure?
20.
It's a range. It's 10 to 20 or 10 to 21 is more specific. Okay. This is the normal range. Above 21, glaucoma. Okay. So now, what can you see over here? What is this disease?
Is this herniated disc?
No, this disc. So we have this is the disc and this is the cup. Is the ratio smaller now between them?
Yes.
Yeah. So this is a feature of glaucoma. Okay, and this is corneal edema. This is acute glaucoma. They'll have a dilated pupil, corneal edema, decreased vision, and then you'll have optic disc and optic cup. And this is the ratios changing here. This is a key factor of acute glaucoma. We'll go into it here, okay? So in open angle glaucoma, the anterior chamber is normal. There's nothing. It's the most common type, especially in the US. There's risk factors in terms of familial risk factor, age, associated risk factors, race, and so on, family history as well, as I said. That's because of decreased aqueous humor. And it's usually asymptomatic and discovered incidentally. That's why I said it's less dangerous. Now, in acute closure angle, the angle is closed. So in this case, they will have severe symptoms. Severe eye pain, conjunctival erythema, sudden visual loss, halos, headache, fixed and mid-dilated pupil, all these things that I just mentioned. In this case, and you need to handle this patient very fast, okay? Now, how do you do that? With drugs, usually. So in this case, you have drugs that decrease synthesis of aqueous humor, and this is usually 3 medications that we can give: beta blocker, alpha agonist, or carbonic anhydrase inhibitors, diuretics. تمام. or you increase the outflow, which is through prostaglandins or muscarinics that you can give, okay? Or alpha agonists. Now, beta blockers such as timolol. Now, something that I want you to remember about beta blockers is if you have a patient with a cardiac or respiratory disease, you try to be careful, okay? Because they can go into either asthma, bronchoconstriction, or bradycardia, okay? That's important for timolol. Acetazolamide does not really have a lot of side effects, I think. That's about the acetazolamide, and it's one of the great drugs we can use for acute closure angle glaucomas. Okay, I'll mention which ones we use for which form of glaucoma. Alpha agonist causes constriction. Tamam. So it has a mydriatic effect, which makes it very important that we be careful in acute closure angle glaucoma. We use it still, but we're careful. Okay. We typically use beta blocker, the pilocarpine, which is a prostaglandin, and the carbonic anhydrase with careful use of this. Okay. So that's basically that. Now, in terms of its adverse effect, it can cause allergic conjunctivitis, which is important, foreign body sensation, blurry vision, and ocular hyperemia with allergic conjunctivitis, especially with this one. Tamam. Then we'll have prostaglandin. This one will increase the outflow through the uveoscleral pathway. Tamam. Now, you have two forms of it. The more common one is latanoprost. The important side effects, which is cosmetic. It darkens the iris color and it causes eyelash overgrowth. This is important. Tamam. Then we'll have muscarinics such as pilocarpine and so on. And its adverse effects, it causes meiosis, which is something actually kind of good in this case, especially for acute closure angle glaucoma. Tamam. So that's basically that. Open angle, we use prostaglandins, usually typically first line. Acute angle closure, we have a combination of multiple of these. This is basically glaucoma, and yeah. Is everything clear till now? We're going to enter the last bit of this crash course.
Yes.
So now the retina. As I said, the retina has two important layers. You have the neuronal layer, which is will have all the rods, the cones, the ganglion cells, and whatnot, all physiology. And then we'll have the retinal pigment epithelium. What's important is the attachment between these two layers. If you have separation of these two layers, the neuronal from the retinal pigment epithelium, this will cause what disorder?
Retinal detachment.
Detachment, which is an emergency. Tom, you already described, you guys are clear with the fundoscopy. Do you want me to repeat how to read the fundoscopy?
Yeah, it's clear.
Tamam. Now, we'll go over one by one. We have this patient who had a sudden onset of flashers and floaters that developed in their, for example, their vision. Flashers and floaters with sudden vision loss. You do fundoscopy, you see this appearance such as a tearing appearance. What is this? Simple. Retinal detachment. Good. Again, an ophthalmologic emergency. Okay. Usually described as flashers and floaters or a curtain drawn down. Appearance in terms of the pattern of vision loss. That's usually how it's described to you guys in cases, and they'll give you this fundoscopy. Key terms. All of this retinal stuff is just remember key terms and important findings on the fundoscopy. Then we have over here someone who has, for example, a thrombophilia. Okay, so they have a lot of thrombosis. Okay, and suddenly they have this. So
Occlusion.
this is what occlusion? Artery or vein?
Vein.
Vein. So this is central retinal vein occlusion, which is a characteristic blood and thunder appearance. Good. Identify only. Not really emergency. Okay. This is an emergency. This causes acute vision loss. Someone who has heart disease, atherosclerosis, develops this. This is central retinal artery occlusion. What do we call this? Cherry red spot. Where is this located in the retina? Macula. Good. So this is what we call cherry red macula. Good. How about this patient? This patient has a relative afferent pupillary defect. Optic neuritis. Here you have optic edema. Can you tell the borders of the optic disc properly? Increase cup size, increase disc size, but you cannot tell the borders that clearly. Here it's messy. So what do we say this? This is optic edema because of optic neuritis. Important things is they have something called a Marcus gun pupil. I think you took this in neuro, but it's relative afferent pupillary defect. Tamam? That's that. Now, important. Someone who has one of the most common diseases worldwide, presenting to you with one of its complications. What is the disease? Diabetes. So diabetes has multiple microvascular and macrovascular complications. Microvascular is 3. You have retinopathy, neuropathy, and nephropathy. Okay? Macro is MI and stroke. Now, in the retina, there's 2 forms, non-proliferative and proliferative. Easy. Now, what happens here is what happens in diabetes if you have basically you have increased thickness of the basement membrane. Okay, that's number 1 because of glucose deposition there. Over time, this causes decreased blood supply to the retina, okay, over time. And this will form new blood vessels slowly. But this is a progression, okay, of diabetes. So in the first step is this step, which is non-proliferative. Here you have a decreased blood supply, tamam, that's causing rupture of these blood vessels because of the weakening of the wall because of glucose. So you'll see these micro bleeds, okay, and you'll see these exudates that build up. This is non-proliferative diabetic retinopathy, okay? Now, because of decreased blood supply, your body reacts by neovascularization, not proliferation of blood vessels, to compensate. So you start to see a lot of plexus of blood vessels. So what do we call this one?
Proliferate.
Proliferative. Easy. This will come in your exam. Okay, most likely to differentiate the two, best on fundoscopy, most likely, or they'll ask you to diagnose. Simple. Diabetes, a diabetic patient, any known case with its complications. What I want you to remember is over here, you can see these neovascularization. Now, the neovascularization can happen at the disc or it could be elsewhere. Tamam. At this point, this is at the disc, and this is elsewhere. Tamam. You can see, for example, very thickened blood vessel. You might see a little bit of bleeds, for example, here or here. And then in non-proliferative, you have all these exudates, and microaneurysms and microbleeds. These are microaneurysms, and then these are bleeds. These are 2 diabetic retinopathy forms. Okay. Do you need to know how to treat it? Just remember photocoagulation, and then here we give anti-VEGF. Anti-VEGF is basically anti-vascular endothelial growth factor, and it basically stops the angiogenesis, stops the proliferation. I don't know if you will get asked this, but this is a potential thing in case. Now, what's important about diabetic retinopathy, or specifically this one, is this proliferation, these blood vessels, are they weak or are they strong? Blood vessels, the walls.
Weak.
Weak. So let's just say someone, in our population, we pray. When they go down for ruku' or sujood, suddenly when they get up, they tell you, I can't see anymore. They develop this. What's this?
Hemorrhage.
Yes, hemorrhage. What type of hemorrhage? Vitreous hemorrhage. Excellent. Good. This is vitreous hemorrhage. Why is this happening? Is these patients have diabetes. These patients have proliferative diabetic retinopathy. What happens is these blood vessels that form are weak. So when they bend down, they increase their pressure. Okay? That will cause rupture of these newly formed blood vessels to form vitreous hemorrhage. This is a complication of diabetic retinopathy. Will cause acute vision loss. Tamam? Is diabetic retinopathy clear?
Yes.
So now we go to this. The sibling of diabetes in terms of chronic diseases.
Hypertension.
Hypertension, exactly. So in this case, you'll see disc edema, arteriolar narrowing, cotton wool spots, which are important in hypertension, hypertensive retinopathy, and then these exudates. Just memorize these findings, but you'll most likely get asked about diabetes more. Now, you have this elderly patient who presents to you with central vision loss. Central. Most of these causes, by the way, are more peripheral. This one is central vision loss.
Macular degeneration.
Macular degeneration. What do we call this at the macula? These deposits. You guys need to tell me it. This is high yield. This is what we call drusen. Drusen. Macular degeneration.
Can you spell it?
Drusen. Okay, drusen. No problem. Drusen is a deposit that's seen in the macula here, these yellow spots. Now, macular degeneration, one of the more common causes of elderly associated vision loss. It's characterized by loss of central vision. Okay? That's the key thing about it. We're almost done here, just a few more slides. Now, I want you to remember the visual pathway. And I think you took this in detail in neuro, but I will go through it because you will get a question on this, 100%. Is we have multiple areas. We have the optic nerve, then the optic chiasm, then the optic tracts. And then the optic tracts will divide into the optic radiations. We'll have the upper and lower optic radiations. Upper in the parietal lobe, lower in the temporal lobe. And it will all go to the occipital lobe. Tamam? Now, we'll start over here. As if you have a defect in the optic nerve, one of the optic nerves, before the chiasm, you'll have this, which is what? Ipsilateral vision loss or ipsilateral anopia. Complete vision loss of that one eye. Tamam. Then over here, the optic chiasm, what vision loss will you have? Bitemporal hemianopia. Hemi means half. Okay, and it's bitemporal, meaning that you have loss of the temporal vision. What's an important cause of bitemporal hemianopia? This is what will come in the exam. Pituitary, adenoma, pituitary tumor. Easy. Then we'll have the optic tract itself. Is if you have the optic tract defect, you'll have contralateral homonymous hemianopia. Done. This is usually due to a stroke. MCA stroke. Excellent. Then we'll have the radiations. If there's a defect in the temporal lobe, which is low, temporal down, صح? So this will be superior defect. What do we call the superior defect? A pie in the sky, which is contralateral superior homonymous quadrantinopia. Not hemianopia. Hemi is half. Quadrantinopia. And it's superior homonymous. Homonymous being affecting both sides. If it's affecting the parietal is up here. The defects can be low. Pie on the floor. Okay? Instead of superior, inferior. Then we'll have any defects to the PCA. If you have a defect in the PCA, you'll have contralateral homonymous hemianopia with macular sparing. So, good. Then this, don't worry about it. Everything else clear? Simple.
Yes.
So now we'll go into some systemic diseases very fast, Asriya. We have this one. What is this? Okay. This is the leash nodules. What is this? Lens opacity. So what is this? Lens is opaque. Cataract. What is this in the skin? This is high yield. So this is cafe au lait spots. So we have a cafe au lait spots, cataract, plus leash nodules, plus this angiofibroma. Don't worry about it. These three together, what do we call this genetic disease that's characterized by optic neuroma, cataracts, leash nodule, neurofibromatosis? And this is type 1. Type 2 causes acoustic neuromas, okay, which will affect vestibulocochlear nerve, will affect facial nerve, and so on. Now, this patient has this stain or discoloration of the face. What is this called? Not Frey syndrome. It's not when they eat. It's not a socioparotid gland excision, tumor, whatever. This is not Frey's. Frey's is when they have, for example, they eat, they have increased salivation and redness at the area of the reculotemporal. Here, it's the whole side of the face is red. This is what we call a port wine stain. Okay, good. This genetic disease is called Sturge-Weber syndrome. What's important about Sturge-Weber syndrome is they developed glaucoma. Okay, that's all I want to remember. This you kind of learned in MSI. It's a form of giant cell vasculitis characterized by throbbing pain, temporal pain, and jaw claudication, which means that every time they open their jaw and they chew, they get severe pain. And you can see here you have optic edema, and then this is a form of vasculitis to giant cell, giant, I gave you the diagnosis, large blood vessels. And it's usually branches of the external carotid, and you can see the superficial temporal here. This is giant cell arteritis. What's important about this is you treat this rapidly with steroids because it will involve the ophthalmic artery and cause blindness. But I don't think you'll get asked about any of this in this block. So, this is low yield. Now, we'll go through 3 slides that are about infectious retinal diseases, then anterior segment and posterior segment, and we're done. Infectious retinal diseases, we have 4 important ones. 3 of these, which is syphilis, rubella, and toxoplasmosis, are congenital diseases, congenital ophthalmologic diseases. These are what we call torch infections, and you learn this more, inshallah, in repro, kaman, in 4th year, inshallah. But basically, these infections are carried through during delivery or during pregnancy, okay? Because of risk factors. Now, you need to know what these different organisms cause in terms of eye infections. Simple. This one is white, velvety. So what is this? In the retina. White and velvety, like everywhere else in the body, candida. Tamam? Now, these 2 eyes have cataracts, okay? Which of these cause bilateral cataracts? I want you to remember rubella. Tamam? Syphilis causes usually keratitis, and I'm not sure aslan if it's I don't think it's this, but syphilis usually causes keratitis, usually causes a lot of stuff. Then you have toxoplasmosis. Toxoplasmosis causes something called chorioretinitis, which is this. Tamam? You need to know this life cycle in terms of its relationship to any the cats, cattle, and whatnot, and how it affects pregnancy. Tamam? That's basically this. And it's straightforward. From all of these, a high yield is toxoplasmosis. Now we go into anterior segment diseases. I do not understand and know what you guys will be tested on with any of these, okay? But I'll explain some of them, okay? But again, I do not think you guys will be tested on this because it's very, very, very advanced for your level to know these diseases and in detail, because you can't just look at a cataract and say, oh, myotonic dystrophy. It doesn't work like that. You might think of it if they have other diseases or other symptoms that indicates myotonic dystrophy or galactosemia or something. Just know the images very well, okay, in case they come, and I'll explain the images and give you the name of the disease. In this case, Wilson's disease is copper, okay? There's copper deposition. If you want to think of what color is copper, it's bronze. Here in the surrounding periphery of the cornea, you'll see this brown deposition. صح? Think of this as Wilson's disease. This is something that we call Kaiser-Fleischer rings, okay? And it's a copper deposition in the Descemet's membrane of the cornea. I don't think you need to know that, but this is what the disease is. It's one of the GI diseases that you'll learn in GI in third year. Wilson's disease. Cystinosis, it's cystine deposition. Okay. Again, I don't think you need to know this. Hypercholesteremia. We said that hypercholesteremia or hyperlipidemia causes xanthelasma in the eyelid. In the eye, it causes something called corneal arcus. Basically, it's this white ring. If you want to remember it, what color is fat? You want to think of it as white. طيب. So a white ring. Some way to remember it. Galactosemia myotonic dystrophy causes cataracts. Okay, not much for you to you just see a cataract, again, you're not going to think على طول, oh, this patient has galactosemia. You go to more common causes. If they're able to tolerate milk, you think galactosemia. If they have muscular defect, you think myotonic dystrophy and some other defects that they have. Then Down syndrome, you have these brush field spots. With, for example, features of Down syndrome. Again, very low yield, but it can come because she emphasized that she would bring one of the anterior segment diseases. So just memorize these images, okay? I hope I made it easier by telling you hints about them. So this one, I'm sorry, there's not much I can tell you in terms of a hint. But here, for example, bronze, think copper, bronze, bronze. Fat, white, white. Down syndrome has a lot of these spots everywhere. Dystrophy and galactosemia is just cataracts. Not much to know about that. Then posterior segment diseases, again, impossible for you to know what the disease is by just looking at the fundoscopy. There's no way. The only one or the only 2 or 3 that maybe will come from here is metastasis, because there's multiple spots. Whenever you have any organ cancer metastasizing anywhere, it will metastasize as multiple spots everywhere. That's how metastasis is. So if it metastasizes to the retina, it will metastasize as multiple spots. تمام. Leukemia, blood cancer. Sickle cell, you won't, yeah, I don't think you'll need to identify it. Hyperviscosity, same thing. You'll learn what this is somewhat in hem-onc, these 2. And then that's pretty much it. This causes optic atrophy. This causes optic atrophy, and this causes optic neuritis. Simply. Same as optic neuritis that we saw, it's the same picture. Different picture, but it's the same pathology. And that is it for this crash course for HNS completely. Inshallah, this was helpful. And inshallah, I covered the important high yields points. For one other thing I want to tell you is a common tumor in the eye that can develop is Kaposi sarcoma. What is Kaposi sarcoma? It's an HIV-related cancer. This is all that I'm going to give you guys. I think we covered it somewhat in MSI. I think. I could be wrong. Or it's in CVP. I forgot where. But anyways, I hope this was helpful. Do you guys have any questions?
Thank you so much. It was very helpful.
No problem. So you guys have any questions tomorrow? I know the exam's on Thursday. Just feel free to reach out to me. You have my number. And I want to emphasize, if for Dr. Salwa, for clinical, make sure you focus on what she emphasizes on. That is my greatest hint I can give you. Anytime. Yalla, best of luck, guys.